Welcome to the Deep Dive. Today we're tackling a medical procedure that's incredibly common, almost invisible sometimes, but absolutely vital. Intravenous cannulation, starting an IV line.
Yeah, it's everywhere in healthcare.
Think about this globally. Over 1 billion IV lines are used every single year. That number is huge.
It really is astonishing scale.
And this seemingly simple thing, it's the gateway, isn't it, for fluids, medications, blood products.
Yeah.
So much essential treatment.
It is. And you might think, okay, it's so common, it must be a totally solved problem.
Exactly. But as we found in our deep dive today, looking at sources like NY-SORA Education, ABCs of Anesthesia, Dr. James Gill, Peanut, Level Up RN, Adiva on YouTube.
And also the more formal stuff like the MSME manual, stat pearls, even patent documents. It shows, a more complex picture.
Right. So for you listening, whether you're in healthcare wanting a refresher or just curious about how medicine works, we want to give you a clear picture.
We're not just going to describe how it's done.
Sure. No, we're digging into why it's so important, the challenges, the things that can go wrong.
And interestingly, a really groundbreaking innovation that maybe didn't quite take off as expected.
Exactly. So the importance, the reasons for doing it, the reasons maybe not to, common mistakes, complications, and this advancement.
So let's start right there. Why is IV cannulation just so fundamental?
Well, first off, like our sources all highlight, it's the main way to get IV fluids and meds into someone. Fast hydration, antibiotics, pain relief.
Yeah, the direct route into the bloodstream. Often the most reliable way.
Definitely. And it's not just for giving stuff, right?
No, that's a good point.
Yeah.
It's also key for taking blood samples repeatedly. You put one line in.
And you avoid sticking the patient over and over again for tests. Much better for them.
Absolutely. And in emergencies or with really sick patients, having that IV access can literally be a lifesaver. Immediate access when time is critical.
It really is foundational. A core skill for, nurses, doctors, paramedics, pretty much everyone on the front line.
It's something they do day in, day out.
Okay, so we get why it's crucial. What are the specific reasons, the indications for actually putting in a peripheral feed?
Well, the number one reason, hands down, is giving those IV fluids and drugs we mentioned. That covers a huge range of situations.
Makes sense. And you mentioned blood sampling.
Yeah. Often, standard practice is to grab blood samples for the lab right when the IV goes in, before any fluids or drugs might mess with the results.
Gotcha. Now, what about the other side? When might a peripheral IV not be the best plan? You mentioned relative contraindications.
Right. So these aren't absolute never do it situations, but more like yellow flags, things that make you pause and think, is there a better way here?
Okay, like what?
Well, one big one is if you're planning to give really concentrated fluids or stuff that's known to be irritating to veins.
Oh, okay. So what's the alternative then?
In that case, you might consider a central line, which goes into a larger, deeper vein, or maybe even an intraosseous line that goes directly into the bone marrow.
Interesting. What about local issues at the site?
Yeah, definitely want to avoid putting an IV through infected skin or burned skin. That's just asking for trouble.
Stands to reason?
Same goes for an arm or leg that's badly injured or really swollen edematous. Not a good spot.
And if the vein itself isn't healthy?
Right. If the vein already has a clot, it's thrombotic, or if it's inflamed, phlebitic, you steer clear.
Okay.
And another important one, if someone has an AV graft or fistula, usually for dialysis, you absolutely do not use that arm for a peripheral IV.
Right, protect the dialysis access. I think I saw something about mastectomies, too.
You did. If a patient's had a mastectomy or a lymph node dissection on one side, the general advice is to use the other arm. It's about potential issues with lymphatic drainage.
Okay, and blood clotting problems.
Yeah.
Coagulopathy.
Yeah, that's another relative one. If someone's blood doesn't clot well, there's a higher risk of bleeding or getting a hematoma, a big bruise at the site. So you use your clinical judgment, proceed carefully.
So it sounds like even deciding where to put it involves quite a bit of thinking.
Absolutely. Previous lymph node clearance, history of DVT in that limb, all things to consider.
Okay, so let's move on to the insertion itself. What commonly goes wrong? The NY-SORA video had some really practical points, things maybe not always in the textbooks.
Yeah, some real experience-based wisdom there. Rushing was a big one they highlighted.
Yeah. Seems counterintuitive in an emergency, maybe.
It does, but they made the point that haste really does make waste here. You put the tourniquet on, but then you need to wait, maybe a minute, maybe two. Let those veins really fill up and become visible.
Give them time to distend properly.
Yeah.
Makes sense. Don't just jump right in.
Exactly. Trying to rush often just leads to missing the vein. It's about respecting the physiology, really.
Okay, interesting. What else? Something about the tourniquet after a failed attempt.
Yeah, the instinct is often to whip the tourniquet off immediately if you miss.
Right. Start over.
But NY Soros suggested, hey, you've already got the veins engorged. Keep that tourniquet on for a moment. Quickly look for another nearby vein. You might save time and effort.
Clever. And what about the catheter itself if you miss?
Another interesting tip. Instead of pulling the whole thing out right away, consider leaving the plastic cannula part in for a moment.
Really? Why?
It can act like a temporary plug, potentially reducing bleeding under the skin, the hematoma. That might make your next attempt at a different site a bit easier, less obscured by bruising.
Wow, okay. Those are some subtle but potentially useful points. What about more standard technical errors?
Oh yeah, plenty of those. Poor technique is definitely a factor. Going in too steep or not shallow enough.
Right.
Or going right through the back wall of the vein, the dreaded double puncture, or transfixing the vein.
Ouch. And patient movement.
Of course, yeah. If the patient flinches or moves, even the best stick can get dislodged.
And sometimes the veins just don't cooperate, right? Vein collapse.
Exactly. They can just flatten out. There are tricks like gentle tapping or maybe having the patient hang their arm down or elevating their upper body slightly, trying to encourage the vein to pop up.
And if you've tried a few times,
That's usually a sign you need help. Ask a more experienced colleague. Or maybe it's time to think about using ultrasound guidance to actually see the vein.
ultrasound seems like a game changer for difficult access.
It really can be.
And the angle of insertion? You mentioned not shallow enough.
Yeah, that's a really common issue, especially for beginners. Not getting superficial enough initially.
Okay. And then there's advancing the cannula.
Crucial point, highlighted by several sources like ABCs of anesthesia, once you get that first flash of blood back in the chamber,
Yes.
you need to lower your angle and advance the entire unit just a tiny bit further before you start threading just the plastic cannula off the needle. Then, once you start threading the cannula, you need to advance it enough. Remember, the tip of the needle is ahead of the end of the plastic cannula.
Ah, right. The bevel length means the plastic isn't fully in the vein yet, even when the needle tip is.
Exactly. That distance varies by the gauge, the size of the cannula. A bigger cannula, like a 14 gauge, has a much longer bevel than a small 22 gauge. You have to push that plastic catheter well into the vein lumen. Not advancing enough after flashback is a super common reason for failure.
It sounds like a real balancing act. Angle, depth, advancement. Tricky.
It takes practice, lots of practice.
Okay, let's flip it. What makes for successful cannulation? The techniques. Our sources were full of good advice here.
Preparation. Preparation is absolutely number one. As Peanut's video showed really clearly, get everything ready first.
Right. Your cannula, antiseptic, tourniquet, flush, dressing, tape, maybe blood tubes. Have it all laid out.
And wash your hands. Hand hygiene is fundamental. Then prepare the patient, explain what you're doing, get consent, make sure they're comfortable, put down an absorbent pad.
Okay, take the bed sheets.
Always. And prepare the equipment, too, like flushing the cannula beforehand, as Dr. Gill showed. Make sure it's patent, not blocked.
Okay, equipment ready. Then the tourniquet.
Right. Apply it, maybe 3 to 5 inches above where you plan to stick. Tight enough to make the veins pop, but not so tight you cut off the arterial pulse. And make sure you can release it easily with one hand.
Some sources mentioned maybe using 2 tourniquets sometimes.
Yeah, that can be a trick for really difficult veins or maybe in very swollen limbs. Helps create more pressure distally.
Then vein selection. Find the best target.
Look for those nice big straight veins. Try to avoid crossing joints if you can help it. Makes it less likely to kink or get dislodged when the patient moves. Sometimes those veins that split, the bifurcating ones, can be good choices as they might roll less.
Makes sense. Then cleaning the skin. Super important.
Absolutely non-negotiable for infection prevention. Chlorhexidine and alcohol swab. Use that crosshatch pattern. Start in the middle and work outwards. And this is key. Let it dry completely. It takes about 30 seconds usually. Don't fan it. Don't blow on it. Let the antiseptic do its work.
Okay, skin prepped. What about stopping the vein rolling?
Good point. Apply distal traction. Gently pull the skin taut just below your insertion site with your non-dominant hand. Helps anchor the vein.
Right. Then the actual insertion. Angle.
Initial angle is usually pretty shallow, maybe around 15 to 20 degrees, bevel of the needle facing up. Insert smoothly through the skin towards the vein.
And watch for.
Flashback. That first little bit of blood appearing in the chamber, that tells you the needle tip is in the vein.
Success. Well, almost.
Almost. Now you lower the angle even more, make it almost parallel to the skin. Advance the whole unit just a tiny bit further, maybe a couple of millimeters,
Ah.
to ensure the plastic cannula itself is entering the vein lumen.
Right.
Then, holding the needle still, you gently slide the plastic cannula off the needle and advance it fully into the vein. It should thread smoothly.
Okay, cannula in. Now get the needle out safely.
Exactly. Release the tourniquet. Place a sterile gauze lightly over the site, above the cannula tip inside the vein. Withdraw the needle smoothly and immediately activate the safety mechanism if it has one.
And dispose of it straight into the sharps bin. No recapping.
Never recap. Then apply pressure over the vein, just beyond the tip of the indwelling plastic cannula, to stop blood leaking out while you connect your cap or extension set.
Then connect and flush.
Connect your access device, your saline lock, or tubing. Aspirate. Gently, you should get blood return if you're properly in the vein. Then flush with sterile saline. Use that push-pause or pulsatile technique.
And while flushing, you're watching the site.
Constantly. Look for any swelling, redness, or ask the patient if they feel any pain or burning. That would suggest infiltration, the fluids going into the tissue, not the vein.
If it flushes okay, then secure it.
Right. Clean off any blood. Apply your sterile, transparent dressing like a tegaderm. Make sure it covers the insertion site well and secures the wings of the cannula. Some people like to make a little loop, a J-loop, with the extension tubing and tape that down too. Reduces tension on the cannula itself.
And don't forget to write the date and time on the dressing.
Crucial for knowing when it needs changing. Then, clean up your mess, dispose of waste properly.
And document everything.
Document the whole procedure in the patient's chart. Gauge size, location, number of attempts, how the patient tolerated it, confirmation of patency, everything.
Any extra tips for those really tough veins?
Yeah, sources mention things like using a warm compress on the arm beforehand, or even a bit of nitroglycerin ointment carefully, obviously to help dilate the veins. Gentle tapping can sometimes help. We mentioned the double or even triple tourniquet technique.
And ultrasound again.
And ultrasound for those deep, non-palpable veins, or after multiple failed attempts. It's becoming much more common.
Okay, so that's the ideal process. But even if the insertion goes well, things can still go wrong after it's in place, right? Complications.
Unfortunately, yes, even with perfect technique. Locally, at the site itself, you can still get problems.
Like what?
Well, the cannula might stop working later. You can get hematoma, that bruising, or bleeding if it gets dislodged. Infiltration, we mentioned fluid leaking out.
And phlebitis.
Phlebitis, yeah, inflammation of the vein.
Yeah.
You might see a red streak tracking up the arm. It can be painful. The vein feels hard. Local infection or cellulitis around the site is possible too.
Can the cannula itself cause problems?
It can get blocked, occluded, or a clot can form around it, thrombosis. And rarely you could damage a nearby artery or nerve during the insertion, even if you didn't realize it at the time. Inadvertent arterial cannulation is rare but serious.
You mentioned infiltration. Is extravasation different?
It is. Extravasation is basically infiltration, but specifically with a vesicant drug.
A vesicant drug.
Yeah, that's a drug that can cause serious tissue damage if it leaks outside the vein. Things like certain chemotherapy drugs and can cause severe pain, redness, swelling, blistering, even tissue death, necrosis, or ulcers. Really nasty. Needs immediate attention.
Wow. Okay, those are local issues. What about systemic problems affecting the whole body?
Less common, thankfully, but can be very serious. Anaphylaxis, a severe allergic reaction, probably not to the cannula itself, but maybe to a drug given through it. Vasovagal syncope, fainting. Some people just don't like needles and might faint.
Understandable.
A catheter embolus is a scary one where a piece of the plastic catheter breaks off and travels in the bloodstream. Very rare with modern cannulas, but possible.
Yikes.
Air embolus, if a significant amount of air gets into the line and into the vein, that can cause a sudden drop in blood pressure, fast heart rate, breathing problems, cyanosis turning blue, needs urgent treatment.
How does air get in?
Maybe from lines not being primed properly or connections coming loose. And finally, fluid overload, just giving too much IV fluid too quickly, especially in patients with heart or kidney problems, can cause breathing difficulties.
It's definitely a reminder that it's not a risk-free procedure, even though it's common.
Absolutely not. Vigilance is key, both during insertion and while the IV is running.
Now, this brings us to something really interesting we found. The innovation by Dr. Cannula. His work back in 1991 was apparently called ingenious and revolutionary by top anesthetists.
Yeah, this is a fascinating part of the story. Dr. Srivatsa basically looked at this procedure, which hadn't changed much fundamentally for decades, and tried to engineer a better way.
How so? What did he develop?
He created a device with a spring-loaded mechanism. The idea was that it would automatically advance the cannula into the vein once blood flashback confirmed you were in the right spot. The goal was first attempt success, even in difficult veins.
Wow, automatic advancement. That's a huge change from the manual technique.
It really is. And his design also included manual retraction of the needle.
So you could control when the needle came out.
Exactly, giving the user control, but also significantly reducing the risk of accidental needle stick injuries, which is a major safety concern.
That sounds incredibly smart.
Mm-hmm.
Any other features?
Yes, he integrated a blood collection chamber too, so you could confirm placement and draw diagnostic samples all in one streamlined device.
Okay.
And it was apparently designed to be relatively simple to use, potentially even by non-doctors in remote areas or resource-limited settings.
So, spring-loaded cannula, safer needle retraction, integrated blood collection, easier usability. This sounds like a winner. It even got patents. Why aren't we all using these today?
Well, this is where the story gets complicated and maybe a bit frustrating. According to our sources, including Dr. Srivatsa's own accounts, the major cannula manufacturers at the time reportedly declined to produce it.
Declined. Why?
The reason given, allegedly, was that the device would de-skill doctors.
De-skill doctors. That
Right.
seems odd. Wouldn't making a difficult procedure easier and safer be a good thing?
You'd think so, wouldn't you? It does raise questions about, perhaps a resistance to changing established practices or maybe prioritizing existing product lines and market dynamics over an innovation that could genuinely improve patient care and safety.
It sounds like potential inertia, or maybe protecting the status quo.
That's one interpretation, yes. Dr. Srivatsa has suggested that maybe the focus wasn't purely on patient benefit. Perhaps market factors played a bigger role than they should have.
So the invention kind of stalled back then.
It seems so. But now, thinking about future pandemics, strained healthcare systems, Dr. Srivatsa has revisited and reinvented his device. It's now called Vanaken.
Vanaken.
Mm-hmm.
And the idea is it could be particularly useful in those crisis situations.
Exactly. When hospitals are overwhelmed, skilled staff are stretched thin. Having a device that increases first attempt success and is easier to use could be incredibly valuable, potentially life-saving.
How does Vanaken compare to the current safety cannulas we use now?
That's a key point Dr. Srivatsa makes. Today's safety cannulas are great at protecting the worker from needle stick injury after the needle is removed. They have shields or retraction mechanisms,
Right.
but they don't actually help you get the cannula into the vein successfully in the first place. They don't address the high failure rate or the trauma to the patient from multiple attempts.
So Vanaken aims to solve both problems, improve insertion success, and provide safety.
That's the core idea. The spring-loaded advancement aims for that first-time success. The manual retraction provides controlled safety. It's designed to be simpler to manufacture, too.
Could it even be used for self-cannulation in some cases?
Dr. Srivatsa suggests that might be a possibility in certain specific scenarios, which is quite a forward-thinking idea.
His argument seems to be about shifting the focus, doesn't it? Towards innovation that directly helps the patient, not just protecting patents or existing ways of doing things.
Absolutely. He believes Vanaken could significantly reduce failed attempts, which means less pain, less anxiety for the patient, lower infection risk, and faster delivery of critical care. Especially vital in tough situations like severely dehydrated patients during an outbreak where veins are collapsed and access is notoriously difficult.
It's a compelling case for rethinking a fundamental tool.
It really is.
So, wrapping this up, we've seen IV cannulation is, well, essential, but definitely not simple. Understanding the pitfalls, mastery of the technique, that's crucial.
Yeah, the basics done well make a huge difference. Preparation, patience, proper technique.
But we've also seen how innovation, like Dr. Srivatsa's Vanaken, offers a potentially transformative approach, aiming for safer, more reliable access, which could be incredibly important, especially looking ahead to future health challenges.
It really highlights that even the most routine procedures shouldn't be taken for granted. There's always room for improvement, and advances here can have a massive impact on patient outcomes, saving lives, really.
Which leads us to a final thought for you listening. Given that the basic IV technique hasn't changed drastically for ages, and considering the resistance that innovations like Vanaken apparently faced, what other foundational medical procedures might be overdue for a similar rethink?
That's a great question.
Where else could a focus on first attempt success, on patient comfort, on simplifying things safely lead to major improvements? It makes you think about that balance, doesn't it? between sticking with what we know and embracing new technologies that could genuinely make things better for patients.
Finding that balance is key, always keeping the patient at the center.
Definitely something to ponder. Thanks for joining us for this deep dive.